Good afternoon. I'm honored to present our study entitled Surgical Quality Evaluation and Phase-Based Outcomes in Gastric Cancer Surgery, Insights from a Single Surgeon's Experience. Before I begin, I have no personal or financial interest to declare. Most studies focus on short-term outcomes after surgical training, but what about long-term quality? What if a trained surgeon adopts a new technique? And how does this change when we adjust for patient risk? To answer these questions, we use a phase-based analysis with cumulative sum, or QSUM. QSUM is a tool that tracks changes in outcomes to assess the quality of surgery. As you can see, when the line goes up, it means complications are higher than expected. But if the curve stays below the threshold, quality is considered acceptable. However, because QSUM treats all patients identically, it does not account for individual risk factors. That's why we applied risk-adjusted QSUM, or RAQSUM, which adjusts complication rates for patient-specific risk. Before introducing our study, I'd like to briefly share a study that evaluated the learning curve of a surgeon performing laparoscopic rectal cancer surgeries. It used QSUM analysis based on operative time, and this declining trend showed that the performance improved as the surgeon gained experience. However, it's important to note that this result may not fully reflect the surgeon's true proficiency, because the analysis was based only on the operative time without considering patient risk. That's why RAQSUM is more appropriate for assessing surgical quality. In this RAQSUM graph, the cases were divided into 3 phases. After an initial learning period, surgical failure decreased, showing technical mastery. But with more complex cases, failure rises again. This shows that even after overcoming the learning curve, a technically skilled surgeon may face higher complication rates when taking on more difficult cases. Building on this concept, we aim to evaluate long-term surgical quality of a single trained surgeon and to examine how technical changes affected surgical outcomes. To more accurately assess surgical quality, we used risk-adjusted QSUM by accounting for patient-related risk factors. We conducted a 13-year retrospective study on 1432 gastric cancer surgeries by a single trained surgeon. Both open and laparoscopic surgeries were included. Surgical failure was defined as Cleveland-Dinto 3 or higher. We used logistic regression to identify significant risk factors of complications and then performed RAQSUM analysis to more accurately evaluate surgical quality. Here are the results. The number of surgeries increased over time. Overall, the complication rate was 19.8%, and severe complications occurred in 5.8%. We then analyzed the risk factors for surgical complications across the entire study period. Among the significant factors were sex, myocardial infarction, stroke, liver disease, and renal disease. Here's the QSUM graph. This curve tracks surgical failure over time, and it's divided into 3 phases. Overall, the curve remained below the threshold, showing stable surgical quality. However, as highlighted in the circled area, there was a temporary rise in phase 2. This appears to be related to a change in surgical approach. Compared to phase 1, the number of open surgeries decreased from 32 to 15%, while total laparoscopic surgeries increased from 56 to 78%. This suggests a technical adjustment period. We then applied RAQSUM to account for patient-related risk. In this graph, the blue line is QSUM and the black line is RAQSUM. While the overall trends of QSUM and RAQSUM are similar, there is a gap in phase 3. In phase 3, the red QSUM line drops more significantly than the blue QSUM line. This suggests that more high-risk patients were included in this phase, and the surgeon's performance appeared even better and more stable despite managing higher-risk patients. To explain this, we analyzed patient factors. Significant risk factors were highlighted in blue. Phase 3 patients were older, had higher BMI, and had more ASA 2 or 3 classifications. Hypertension and congestive heart failure also significantly increased, confirming a higher risk group in phase 3. To conclude, both QSUM and RAC-QSUM showed that the surgical quality remained stable over time. New techniques temporarily increased complications, but with acceptable limits. RAC-QSUM confirmed that the quality remained even with high-risk patients. Thank you for your attention.